So today, colleagues, our session 1 title is Sharing Success Stories on Global Fund Proposal Preparation and Reprioritization. My name is Rita Lolo, and I'm the PI for the CDC Union Cooperative Agreement. I apologize for my somewhat abnormal voice. I have a mild laryngitis at the moment. However, I'm very delighted to join all of us today. So once more, welcome. And this session is indeed part of the Union's Sub-Saharan Africa Regional Child and Adolescent TB Center of Excellence's ongoing activities and the workshop series on this particular topic to support you, colleagues, in the COE member countries to prepare and reprioritize and generally to interact and work with Global Fund. This is in anticipation of the new grant cycle 8 being already under preparation. So I would like to welcome all of you once more most warmly, and I would also like to recognize the presence of our colleagues from the Global Fund Against AIDS, TB and Malaria, most notably my co-facilitator, Dr. Grania Bridger, today. The objectives of today's sessions are to showcase success stories from COE member countries that have effectively integrated child and adolescent TB into Global Fund proposals, and to strengthen cross-country learning by sharing real-world examples of what has worked and what has not worked, and how challenges can be and were overcome. We have two presenters today. It's Dr. Immaculate Kature and Dr. Maureen Sekade. I think all of us know you, Dr. Kature. You have extensive service and extensive experience over many, many years in TB with special interest in child and adolescent TB. And we are honored that you, as the NTLP manager for Kenya, have found time to join us today. Immaculate will now share her country experience, how to successfully integrate child and adolescent TB into Global Fund proposal. Dr. Kature, over to you. And perhaps you wish to tell us whether you want Rita or yourself to project the slides. Over.
Hi Rita, this is Pauline. I apologize on behalf of Dr. Kathure. She may not be able to join, but Dr. Macharia is joining to present.
Oh, wonderful, wonderful, Pauline. So a small correction, colleagues. Immaculate may be unable to join us. However, we have got a presentation from Kenya. And did I understand correctly that Dr. Stephen Macharia will be taking us through the slides and discussion? Over to you. Over to you. Thank you. Thank you, Pauline. Steve, are you online? Or are you together with Pauline by any chance?
So Dr. Stephen is trying to connect. He has some internet changes. Maybe you'll also need to help him project.
Okay. Rita, are you kind enough to take up the slide set and perhaps share your screen while we wait for him to get online? Thank you very much. I see the slides coming on. And if there are any delays with Dr. Masharias joining the call, would you, Dr. Maureen, be able to jump in earlier than expected as per the agenda?
Yes, thank you very much. I can present. I also request Rita to help me share the slides.
Thank you. Pauline, would you be able to message to Dr. Stephen that he has a little bit more time to log in?
Okay, let me do that. Thank you.
Thank you so much. Thank you.
Hi, Maureen.
Hi,
Please
Rita.
confirm if you can see the screen.
Yes, I can.
Over to you.
Okay, thank you very much. I would like to take this opportunity to appreciate the organizers for this workshop series, and again for inviting Uganda to share the experience in integrating child and adolescent TB into the Global Fund proposals for TB, HIV, and malaria. And I'll be presenting on behalf of the TB program. So that is the order of presentation, context, examples of the strategies that we applied, the activities that have been funded over time, what opportunities did we document, and then just a snapshot of the data that we are posting. So Uganda is one of the 30 high burden countries for TB and TB HIV, with an estimated incidence of 197 per 100,000, according to the most recent Global TB Report 2025. We also have about 177 new and relapse notifications per 100,000. When it comes to children, we have an estimated number of 14,300 with a treatment coverage of 70.5%, again, as based on the most recent Global TB Report. Next slide, please. So what strategies have we applied as the program, as Ministry of Health? So during the preparation process, of course, the preparation starts way before the submission windows. We have endeavored to ensure that the activities proposed are aligned to the Ministry of Health strategic direction and priorities, and here particularly the strategic plan for the National TB and Leprosy Program, where we have a strategic objective that is focused on improving TB treatment coverage for children and adolescents. And we also ensure that the national policy and guidelines are aligned to the most recent or most updated global recommendations. So that is one thing that has really pushed us forward as we advocate to include interventions and activities within the global funding application. And this is premised also on data use. We do have program indicators that focus on children and adolescents. The specific ones are treatment coverage for children and adolescents, where we aim to achieve at least 90% in line with the End TB strategy. We also have indicators that are focused on the proportion of people with TB notified as children under the age of 15 years, and we do have a target of about 15%. We also have other indicators that are cross-cutting under prevention, under access to molecular testing. So we have really prioritized to use data, and this has also been used for demonstrating a successful implementation and dissemination of intervention and activities. We have engaged stakeholders for consensus and advocacy as we identify activities and also prioritize these activities. We do have a multi-stakeholder pediatric TB technical working group that also includes civil society. So we engage the stakeholders early on, and it's great that we are having this workshop series as we prepare for GC8. So we run them through the performance, we review the strategies within the strategic plan, and then we also follow through in the writing process. We endeavor to have representation during all the writing workshop to ensure that the proposed activities are included and are fine-tuned as we go through the writing process. These stakeholders are also engaged during implementation, so they also have a feel of what happens within the field with respect to activities that have been funded within a particular grant cycle. And then they are able to also reflect and make suggestions on how to improve and how to scale up the proposed activities. The other important thing that we have really leveraged is evidence translation and scale up. So we do have a homegrown research projects, interventions that focus on child and adolescent TB. These have been successful, and we have used this evidence to also back up the rationale, the justification that is included within the Global Fund application. Examples include the Detect Child TB, CAP TB, TB Speed, and also our interventions that are specific to integration into school health. So the evidence generated from these particular interventions has improved the narrative for the application, but also as we implement, we are able to fine-tune the proposed activities. The other important strategy is a collaboration and integration across programs. We do know that the Global Fund grants span across TB, HIV, malaria, and even there we do have the system strengthening bit of it. So we have leveraged the collaborations that we have, TB, HIV, even for malaria, especially the community level interventions. So this has also enabled us to see that a component of child and adolescent TB is also catered for. And then the other strategy is really looking at absorption of allocated funds. So we have so the funds for the different cycle have been utilized, and this has also provided confidence in future allocations where we have been able to see an increase in the number of activities that have been funded. So once the absorption is good, there is a confidence that implementation can happen in future grant cycles. Next slide, please. So here we have a list of interventions or activities that have been funded within the various Global Fund cycles, starting from NFM2, where we had an activity on conducting mentorship for childhood TB with emphasis on clinical diagnosis using the Detect TB approach. And as I said, the Detect Child TB approach was an implementation research project that was two-pronged. It had facility-level interventions and community-level interventions, and we did see an increase in a TB case notification for children, as well as the uptake of a TB preventive treatment. So we had this evidence, and it was used to justify for the activities that are targeting child TB. So within NFM3, we saw scale up to 50 districts. In NFM2, we received funding within 10 districts. So we were able to advocate, and this was increased to 50 districts, including aspects of school health. And then for GC7, we see that we were able to obtain funding to scale up to an additional 96 districts. And here we included enhanced Detect Child TB. The enhanced bit was informed again by other projects that had been implemented in the country, CAP-TB, TB Speed. So we were able to improve the earlier implementation so that we are able to reach the individuals that we were targeting. So within the current GC7, we are scaling up to an additional 96 districts and prioritizing those that have a low TB treatment coverage for children and adolescents. We also have an activity on annual on-site mentorship, targeting 90 districts and 180 sites. The last activity within this grant is implementing TB awareness and screening activities targeting children and adolescents in and out of school, including the adolescents and young people. So these are the activities that have been funded by the Global Fund within the different cycles. Next slide, please. So what opportunities have we documented? We do see that for NFM3 and GC7, there were specific interventions targeting children and adolescents, key populations. Under NFM3, there was a module on key populations, TB care and prevention, children. Similarly, for GC7, under the key vulnerable populations, children and adolescents were highlighted. So this really provided a strong initiative for us to be able to advocate and include activities that target children and adolescents. We have also leveraged the implementation across programs I had earlier mentioned. Of course, the funding under the Global Fund would not cover the wish list for child and adolescent TB programming. So we leverage implementation across other programs, for example, HIV, malaria, as I had indicated. And then we are able to see that the children and adolescents at risk or with TB are not left out. We have also leveraged other non-GF funding streams and interventions, of course, not forgetting the government. We have also implemented specific interventions, for example, the scale up of the Simple One Step that was funded by TIFA. We have also implemented together with the HIV program, the Stop AIDS package scale up with funding from PEPFAR, with funding from CHAI. So we leverage other non-GF funding streams to ensure that these populations are not left out. And then we also have the ICCM that is also implemented under the malaria program. Next slide. So this is just a snapshot of our data. Over the years, we see that we have had an increase in number of children identified with a tuberculosis. We see a drop in 2023, 2024. So the program is currently undertaking steps to analyze this drop. And this was also part of our recommendation from the end term review to really look into the root causes for this drop, but we see that we have progressively had also an increase in the proportion of the proportion of individuals with TB that are children under 14 years. Next slide. I think the last one, yes. So these are these efforts, it's really a combination of efforts towards the response. Very important to emphasize is partnerships and collaboration at all levels of care. And then integration, which is also becoming a very critical component as we move forward. And we also, as a country, conduct a nationwide biannual TB campaigns that have also bolstered the efforts to case finding. And the last slide should be acknowledgement. The government of Uganda, and this is in no particular order, the different funding agencies and the community that we serve. Thank you very much. Over to you, Rita.
Thank you, Maureen. That's really great to see, and really like the sort of final slide of showing the increases of pediatric notifications over time. So I'm hoping now that we have Dr. Stephen Macharia online, who is standing in for Dr. Kathore to represent the TB and lung health program for Kenya. And Stephen, if you are online, just unmute yourself so we can just make sure you're online, and then I think Rita's sharing your slides.
Yeah, sure. Good
Perfect.
afternoon
Thank
to
you.
all. Please confirm you can hear me.
I can hear you well.
Oh, great. Thank you so much. And sorry for this late entry into the meeting. Yeah, I'm presenting on behalf of Dr. Kature, and I would request that you roll the slides for me. Now, I think the first slide just talks about the Kenya TB burden. Sorry, this slide is really not updated. We have the 2025 reports, whereby the TB incidence for the country is now at 117 per 100,000 population. We notified around 95,000, and so we still have quite a number of patients who are being missed. And the treatment coverage for the country has actually also moved to about 81%. And the mortality is also showing a decrease for that year. We had 16 for those who are not HIV infected, but combined the two, we are at around 24 per 24,000, which actually hasn't changed much depending on the current trend we have. So we are actually moving towards the changes towards the milestones for the NTB strategy of 2025, but we are still here to measure that so that we're able to right. Next slide. This slide just shows an overview of the country achievement in the year 2024, where looking at the total TB cases notified, which were about 96,865, we have a pediatric case finding of about 13% of those 96. And the DRTB cases also has relatively were 751. But if you look at the for pediatrics and adolescents, I think in that proportion you see that the 0 to 5 we have 93, 94%, and so we are actually ranging between 93 and 94 for those for pediatric and adolescents. TB case finding. The case treatment success rate we are at around 89%. And if you look at the sector contribution, we have public private sector, which is contributing about 24% of the entire case notified. The country is rolling out digital X-rays, and as you can see, we have quite a good proportion of patients who are able to receive digital X-ray, and this number is slightly increasing, and we still continue to see some improvement into regards to the uptake of especially digital chest X-ray with AI and for those lower level facilities. So for contacts, listing of the contacts is at around 40, and we are able to initiate about 83% on ART. Let's move to the next slide. The next slide just shows the trends in DSTB case finding for the period 2011 to 2024. As you see, we had two dips, and the reason 2016 we did a prevalence survey. We had the new strategies, so we rose it. We actually increased the number of cases. Then we had a drop in 2020 due to COVID. But from that time, we are actually seeing an increase in cases, number of TB cases that are being notified. However, I think for the last 2 years, they are stagnated at around 97. However, the pediatric case finding is actually at around 13%, which is slightly below is within our target of 10 to around 15, 12 to around 15%. Next slide. This slide shows the diagnostic criteria, and we are comparing the year 2024 and the first quarter of 2025. As you can see from the slide, I think majority of our patients are clinically diagnosed, and but you can see as bacteriologically diagnosed actually improves as we improve as the age increases. And you can see at around, we're comparing to this quarter, I think we are seeing an improvement in those cases, especially for the age group 0 to 4, and of course 10 to 14, which could be attributed to new diagnostics. I mean, the new innovations and new diagnostic processes that the country is adopting currently. Next slide. This on DRTB case notification. I think you'd appreciate that, well, we have actually had a decline up to around 2023, but we are definitely trying to increase now the number of cases that are actually being diagnosed with DRTB. But for pediatrics, children rather, under 15 years, you can see we have actually stagnated. I think the highest we have had is currently at 34 cases, this absolute number. So I think with the improved access to DST, we are seeing also an improved number of pediatric TB cases that are being enrolled on treatment. The next slide actually speaks into the issues of TB contact screening cascade. And as you see, I think for us, our entry point for contact screening is from those who are bacteriologically confirmed. And our guidelines or our targets is like we need to have 1 to 3 ratio for the expected contacts. And so based on those contacts, about 150,000, the ones that have been listed are about 40%. But you can see that the screening has actually, those who are screened, of course, the screening that is here is based on the number of contacts. I mean, we are also basing it, of course, on the expected contacts. That's why we are talking about 38%. But you can see the screening within those who are contact contact line listed actually is quite high, and those eligible for TPT, we are also having around 96% of them getting treatment. So for pediatric and adolescents, I think line listing is at 2%. Screening is at 97, initiated on treatment at 98, and treatment completion, I think, is at around 92%. So I think this lower one shows where pediatrics are in relation to the overall picture. Next slide. We see that actually our strategies are aligned to a national strategic plan, which lasts up to 2028. So we had under an outcome specifically addressing the children, childhood TB, and we expected to increase the notification to about 12% by 2028. But of course, now if you look at it in this respect, I mean, the gaps that were there, of course, were index of suspicion among healthcare workers being low, and we had also some factors that contribute to increased TB among this population, like malnutrition, among other things. So the strategies that we are using was more to improve this by to detect, improve on how we detect TB in children. And this was basically looking at how do we build capacity of healthcare workers and how do we create demand for TB services for adolescents and of course looking at where most adolescents are, which is actually in school and colleges. And of course there were expected strategies which I think have actually been aligned some. Next slide. This slide now speaks into, the indicators I had and mixed. So there are those indicators that we are monitoring. And you see, when we're making the childhood proportion of, so we're looking at the cases notified, the treatment success rate, and of course, looking at TPT as the three. So we had the baseline, and we have ambitious target, especially for TPT, to ensure that 70% of this population have over 5 access to this. Next slide. So this slide just gives us an overview of what the modules and what have actually changed. So if you look at the previous GC6 modules and intervention, in the new module, the current GC7, I think we have a module that specifically speaks into childhood and adolescents under the key and vulnerable population. But of course, the services that are geared toward this, some are very specific towards this, but most of them actually cut across other modules, especially for treatment and diagnosis. For screening, diagnosis and treatment. Next slide. So the funding request process, of course, as a country, we have actually used consultative processes to engage stakeholders. And this cuts across those who are within the health systems as well as the communities that are affected. And this includes, so we have experts, TB experts within the country, and also we have a childhood TB technical working group that aligns all the strategies towards our NSP and of course this funding request. So the gap identification included mapping of the barriers, gaps affecting childhood TB, and setting priorities for childhood. Next slide. So the barriers that were identified during this process, one was ensuring that we have in the integrated guideline, we have guidelines that actually the barrier was that first of all, the barriers were not actually addressing the issues of childhood, especially childhood and adolescence. And so the guidelines, that was one of the barriers. The other one was limited access to linkages, where we want to involve key vulnerable population, TB screening and prevention. There was issues of healthcare having inadequate knowledge in screening and diagnosis of TB, and that one, of course, lowered the index of suspicion. Issues of resources, of course, the insufficient programming and funding for advocacy outreaches and support targeted interventions vulnerable groups. Advocacy was also mentioned as one of a weak point. There was also the absence of advocacy initiative, specifically that was actually targeting children in community programs, and limited data limitation due to issues to do with estimated size estimates as well as geospatial distribution of vulnerable groups that were hindering coverage. Next slide is on the say as a continuation. So I think this is already talked into, but I want to talk to the second and that. We are limited capacity among healthcare workers to obtain samples, as well as limited contact tracing for children, contact for TB, limited X-ray services. So those were other things that were actually identified. With adoption of new tech tools and technologies, fertility cancer children, of course, would be achieved. Next slide is prioritizing intervention in the funding request. So the issues of having meetings to complete and disseminate policy guidelines, which had actually already been initiated, which I'm happy to report that that is done. We're creating awareness in institutions of learning and including even the teaching staff, issues of having developed targeted IC materials for children and adolescents to disseminate information. Also doing a review of HIV, CHV curriculum to include pediatric context, and also doing targeted outreaches, especially in the learning institution, to ensure that that's done. So in the childhood TB enablers, for this, I think we are looking at how do we anchor national strategy data, okay? And I will also looking at how do we generate evidence-based regimes and packages, as well as how to integration of childhood into primary health care. Other issues that we are looking at, taking place, age segregation surveillance, so that we're able to routinely monitor these groups, as well as strategic partnership to ensure that we're able to leverage TB partners to strengthen integration and country implementation. Next slide. So some of the lessons that we have learned, one is being explicit on bottlenecks, that's low suspicion among providers, and diagnosis require a lot of inputs like training, algorithms, review of algorithm, as well as the tools, especially the new tools that are already being implemented. Then there is issues of prioritizing integration. So better review outcomes, which will help us to review outcomes and clearly integrate progress, integrate across prevention, diagnosis, treatment, community system, and data. And of course, the numbers that matter. So age desegregation baseline. I think this coverage gaps and cost at scale up pathways can actually strengthen case finding. Lastly, I think this is the second last slide. So some tips is how do we crosswalk every intervention? Okay, so we look at WHO roadmap as well as NFRP. Then, of course, the GF, the modular framework, and all those things I think we need to look at when we are writing the GF application. Then there's a proof of delivery of systems, ensuring that the budget for age disaggregations, digital surveillance. I think all these delivery systems needs to be looked at. What costs can be scaled up, and of course also look at show feasibility of momentum. That's the difference to the current co-financing. And lastly, I think future consideration is how do we integrate entire adolescent cells into lung health services with a focus on post-TB lung diseases screening. How do we also do research on the new tools? I think currently we have validation of AI, digital X-ray for diagnosed chronic lung disease children, as well as evaluating also the digital X-ray with AI as initial screening tool. Then, of course, issues of strengthening integration of TB into maternal neonatal child health, nutrition clinic, all aspects that are looking into issues of children and adolescents at all levels, and then leveraging on the health programs to accelerate active case finding. So I think that's all that that is there, and I hope I was able to be heard, and back to you. Thank you. This was the last slide. Thank you.
Thank you, Dr. Stephen, and another great example of kind of proactively thinking and the impact that that's had over NFM3 and GC7. And I think both your presentation and Maureen's one on the sort of role of integration is really good to see. And I think you may have seen from the reprioritization process that many of the programs have just been through, kind of integration, appropriate integration as an efficiency is really key, and I think we will continue to be seeing that into GC8. So great that both Uganda and Kenya have already started that. So I think now we'll just open it up to the other COE countries to see if you would like to share any of your recent experiences, both from the sort of GC7 funding request writing and how you incorporated child and adolescent TB, and or any experiences from, I know many, all the countries have just come out of the reprioritization process, and if there are any reflections there. So opening up the floor to just see if anyone would want to share anything, otherwise we can go into some guided questions. So either put your hand up or please feel free to just unmute and share any thoughts that you have from your national experiences from the Global Fund Child and Adolescent TB. Okay, I'm not seeing any hands up. So then maybe I will just start with a more focused question. And I think just to build on what you've heard from Kenya and Uganda on the strategies that they used to help ensure that child and adolescent TB was prioritised during the funding request. I'd like to ask the others on the call if you would like to share your strategies that you have used to make sure that child and adolescent TB is in fact has been prioritised within your GC7 funding request process that may be helpful to other countries as we start the GC8 planning processes. Okay, anyone got any thoughts they'd like to share on that, or either some of our partners on the line? Okay, we're being a quiet group today. Okay, so maybe Kenya, Dr. Maureen and Dr. Stephen have covered all the strategies, and there weren't any other strategies that others would like to share of how they've tried to really think about prioritization. So I think then maybe I'll go to the next question. And I think this would be really great to hear from the group of kind of if there were clear activities put in to the GC7 funding requests, sort of what challenges did you experience when sort of really trying to integrate child and adolescent TB both into your TB your TB work, but also both as Dr. Stephen and Dr. Maureen mentioned, kind of that integrating it into maybe some of the child and maternal health activities or the HIV work. What challenges did you find in implementing that? Any thoughts on that?
Yeah, okay. I think maybe I can just go first.
Great,
Well,
please do.
I think when it comes to the issues of the clear activities that needs to be done in GC7 request. Of course, we understand that this GC7 that is actually the GC7 itself, first of all, was prioritized, okay, a prioritized funding request. And then, of course, there was these aspects of, again, reprioritizing it again. So that now, at least at some point, maybe there was that loss of focus where one had actually looked at trying to expand in future, but now you have to actually start narrowing down again. I think that in itself causes a little bit of but that's a good learning lessons because I feel that with that, then other countries have been able to move back and try to ask ourselves, how do we achieve the same impact with the resources that are available? So these activities, the challenges, of course, that comes in is one is because of course, the resources have to be competing. There's competing of these resources among other modules, and of course that itself becomes a challenge. Now, coming to the issues of having now the pediatric case finding within the facilities, I think one of the key challenge that we face is that at times that kind of clear cascade of services of between screening, presuming investigation, and of course treatment sometimes not clear among all the healthcare workers, and that of course makes the index of suspicion of TB among these the other cadre being a little bit lower. But I think with the continuous kind of mentorship and of course on job training, and of course displaying ensuring that there's a continuous medical on-job training or continuous medical education in those particular departments within the institution actually would help in itself to reach to the other cadres who can also be able to find. Again, of course, I think linking, we know there are the issues of screening algorithm. I think the one that, for instance, Kenya is using is quite sensitive because it has quite a number of questions, which of course, if quality is put into how those symptom screening is actually done, then actually we'll be able to also be able to find a little, more numbers in regards to the number of children and adolescents that we have. Three, I think the issues of, again, of course, the diagnosis of TB again. We know that as you saw, of course, the bacteriological confirmation, as the higher you, the higher or the older age groups, of course, since they're able to expectorate and give sputum, of course, the bacteriological confirmation at that point is quite, it's relatively higher. But of course, with the new technology coming in, I think we could also be able to reach these lower other populations. Thank you. I think that's all I have for now.
Great, thank you. That's great. Theo Dejuni, I hope I've said your name correctly. Sorry.
Yeah.
Please go ahead.
Perfect. Yeah. I think my question to the two presenters and also for the experts in this area on the forum is how do you balance the need to scale up community services for case finding, because I think that's what matters the most when it comes to TB. We are finding that most TB cases are being identified in the community. The more we stay in communities, the more we in facilities, the more we stay stagnant. So I think the TB programs are going towards community approach more and more, and I think this presents a challenge for pediatric TB case finding due to the need for a skilled workforce to be able to screen, diagnose, especially the clinical diagnosis, and also collecting the sputum through different techniques. So I don't know what best practices are out there for being able to roll out that to community-wide specific tools that are available to help countries to really integrate pediatric case finding in different community outreaches. Over.
Great question. And I think you are, yeah, I think that is a challenge as we potentialize, because we know that that's where cases of TB tend to be, and we're only seeing the tip of the iceberg of those who present. Yeah, and I think as Stephen was saying, there are some new diagnostic tools. I think the near point of care test and the option for alternative sampling techniques such as tongue swabs that may help us slightly, but I think the data in children is not large, and I think it is increasingly pointing that it may be a concurrent approach rather than a sort of it's going to solve all of our problems. But it would be great to get a sense from any of the other countries and programs on the call of kind of how they're thinking about and addressing the decentralization and facilitating pediatric TB into the community services. So it'd be great to hear if anyone's got any thoughts on that or how they've been doing that. And I think Stephen touched on it a bit as well. Anyone want to add on that? But a great question.
So I think yes, Granny. I think another aspect maybe of would actually trying how we can actually be able to intensify contact management or contact management of cases, because I think for every maybe adult who has a child, actually most I mean that community transmission actually might actually have occurred. So I think that strategy of enhancing that contact management would actually also help us reach cases that actually are being missed at the community level. Thank you.
Thank you, Stephen. Indeed, I think when I worked at MSF, we always said, think about the child on the knee. Often the adult has a number of children at home, so contact tracing is a great entry point. Samuel, I see you had your hand up. Did you want to add anything or share any of your experiences? Please go ahead.
Yes, thank you. So I'm Samuel Chiro from Malawi National TB and Leprosy Mission Program. I'm the desk officer for pediatric TB. So in terms of what we have done, the main challenge for us has been a centralized capacity for pediatric TB diagnosis. So most of our cases in the past decade or so have always been diagnosed mostly in the majority, over 60%, at referral hospitals, especially the two referral hospitals that we have, which is Kamuzu Central and Queen Elizabeth Central Hospital. So having noticed that, we have begun to decentralize, but I think as we're aware that the challenge with the Global Fund is there aren't a lot of pediatric TB specific activities. Typically they're integrated into other activities, but the time to actually capacitate someone in terms of the clinical aspects of diagnosing pediatric TB is typically not enough, maybe 1 hour allocated. So with the little resources that we've had, we have targeted the pediatric inpatient wards and the nutritional rehabilitation units, and targeted clinicians and nurses from those departments. So we are starting with district hospitals for now. Though the numbers are quite small, but we are seeing some results in terms of in those districts that we have capacitated that department in itself, they're able to diagnose cases which previously wasn't the case. We do know that there are other departments such as the under 5 OPD, the RT, that we will have to capacitate clinicians in those departments. But with the resource limit, that poses a challenge. We do have stool testing as part of the national policy, but the problem becomes that while we have this as a policy, the clinicians and nurses to actually send those samples lack in capacity. So we have noted that we have trained lab officers in stool testing, but they're not getting any referrals because the clinician aspect and the nurses are not able to pick up those cases to send the samples. So we are making quite the slow progress, but we're seeing some results. Thank you.
The dates and you send us an email so that.
Thank you for that, Samuel. And it's great to hear your thoughts and feedback on that. And I think it kind of, and maybe others can share of maybe that sort of phased tiered approach to moving outside centralized services, and I think focusing on nutritional services is a key area, and then as you say, kind of moving to that under 5 years OPD is probably another area where lots of undiagnosed pediatric TB resides. I'm going to have to make my apologies because I have a hard stop on the hour. So I want to thank the union and the Centre of Excellence for inviting me to co-chair this with Rita. And we do look forward to the series in preparing for GC8. So I'm going to hand back to Rita to continue to moderate the discussions. But just personally, I want to thank both Maureen and Stephen for their great presentations today and for the conversations. Apologies, I have to leave, but I look forward to continuing this conversation with you all in 2026. So Rita, I'll hand over to you to continue the Q&A, but thank you everyone and apologies for having to leave.
Thank you, Grania. Much appreciated, and I also reiterate the thanks to the presenters. We have a few more guiding questions, but at the same time, I do recall the wish and advice from our audience, from you colleagues, that we would keep these sessions to 60 minutes. So I propose that we park those questions, because indeed we have subsequent sessions planned for the series, and we will be coming back to the very same issues in future sessions. Before handing over to Welile and the closing remarks, may I please ask you, Rita, to kindly share your screen with a couple of slides just to summarize what to expect in the future, colleagues. So indeed, this is the last session for this year. Let's put it on the presentation mode. Thank you. And in early 2026, probably in February, we will be having a one-on-one on Global Fund processes. And you will have a chance to have a question-answer session with the senior TB technical advisors housed in Geneva. Next slide, please. Sessions 3 and 4, we will look at innovations and integration, and once more re-examine the technical priorities of the Global Fund as they pertain to our area of interest, that is child and adolescent TB. And in the last session, also based on our consultation roughly a year ago, we will try to look into the costing and budgeting for child and adolescent TB activities. We need to be aware what the costs are associated with our various interventions so that we can ensure that we get the best return for the dollar. And the last slide summarizes a couple of Global Fund's information resources. Colleagues, you may already be aware of the general page and also for some information on apply for funding. Some may be repetition if you have attended some of these sessions earlier on, but some may be very worthwhile refreshers. And especially if you're a new member in the team that is anticipated to work on the Global Funds Grant Cycle 8 documentation, I warmly recommend these sessions to you. If you have any further questions to any one of us or our colleagues at CDC or Grania in Geneva, please do not hesitate to write us an email or contact us through the WhatsApp group. Over to you, Welile, for closing of this session. And thank you from my side. Thank you.
Thank you, Rita, and thank you to all our presenters and participants for your valuable contributions today. Your practical insights and experiences help strengthen regional capacity and ensure that children and adolescents remain visible and prioritized in the Global Fund investments. The COE is committed to supporting countries throughout proposal development and reprioritization, and we hope the lessons shared today will continue to inform and inspire your continued work. Thank you once again for your active participation, and we look forward to continuing to engage with you as you all go through the Global Fund application processes. As Rita has mentioned, if you have any questions or would like to reach out to any of us outside of these sessions, please do not hesitate to do so. We are more than happy to continue to support you as needed. Thank you.
Thank you very much and bye.
Thank you. Bye
Goodbye,
bye.
everyone.
Thank you. Bye.
Thank you and bye.